This morning we have Dr. Palani from our radiology department giving our grand rounds. Dr. Palani completed his medical school as well as his radiology residency in India before coming to complete his pediatric fellowship here at Miami Children's Hospital. He joined Norton's Children's Hospital in 2010, and he has multiple publications and will be speaking today about hemangiomas in infants. Dr. Palani.
Good morning, everybody, and thank you very much for the introduction. What he probably forgot to tell was that you guys were supposed to hear a great lecture today, and then my colleague had something else to do, and I had to fill in the shoes. But that being said, this is a nice talk, and this is based on a poster that we published as well as presented in 2010, which won an award in the Society of Pediatric Radiology for John Caffey. For those who don't know John Caffey, he was kind of the father of pediatric radiology. But anyway, so the talk today will be on infantile hemangiomas. Objectives. At the end of the talk, I expect people who are not sleeping during the talk to, at least understand to use the term infantile hemangioma appropriately. If nothing else, please do not call any vascular lesion in a baby infantile hemangioma. And I will also be saying that most infantile hemangiomas do not need imaging or advanced evaluation of any sort. But some of them do, and which is why, as the talk goes, I will be pointing them out. This is a quite busy slide, and again, for the most of this talk, any busy slide, I'm kind of going to skip it. I'm not going to go into in detail. People who are interested can look at it. The purpose of this slide, which was kind of drafted in 1995 by that society, was to separate lesions which had been, till that time, everything was called a hemangioma. Everything, vascular lesions, portwine stains, lymphatic malformations. That led to a lot of confusion in diagnosis, treatment, prognosis, and even knowing what was what. So they came up with the society. They keep on doing the updated publications. But this one basically states that anything that has mitotic activity comes under the tumor. Please note that infantile hemangioma is a tumor, but it's a benign one. And it's a very unusual tumor in that it resolves or it involutes on its own. Whereas the other ones, the malformations, are not tumors in any true sense of the word. They are there. They are an anomaly. They are not tumors. They do not proliferate. They can increase in size, but they do not proliferate. Again, a busy slide, but I want you to focus on the picture because this picture is kind of what I'll be pretty much speaking for the next 30 minutes or so. And if you look at the picture, so hemangiomas can be subdivided into two categories, the congenital hemangiomas and the infantile. As the name suggests, infantile happens only or starts in infancy. It's not present during birth at all. You can have a precursor lesion, but the tumor or the mass itself is not there at birth. If it's there at birth, we have something called a congenital hemangioma, which can be further subdivided. I'm not going to go into detail into those things, but we'll focus on this one. They present shortly after birth. They are not present during birth. You can have a precursor lesion. I'll show you one of those pictures, but you don't see a mass at birth. Usually it happens between week 3 to 4. It's almost always there as a mass by month 2. So not seen at birth, but comes after birth, keeps on growing really fast between 4 and 8 months. That's when they grow very, very fast. And then after a year, they kind of plateau and then start involuting. So by age 3 or 4, it's not really a mass anymore. It is GLUT1 positive, and this is important for diagnosis. And the other things we will cover later. Please do not use those terms as capillary or strawberry because, yes, we are trying to describe it, but trying to label a lesion with those terms just adds to confusion. If you're not sure, you can say, I'm not sure. If you know what it is, then you can go ahead and call it an infantile hemangioma or a congenital one. So some pictures, kind of show that infantile hemangiomas can be of various sizes and shapes. Can happen at many places, but nearly 60 to 70% of them happen in the head and neck region. So that happens because of an dermatomal distribution and etiopathogenesis. I'll kind of briefly touch that in the next few slides. But again, they can be focal, they can be along a dermatome, which case you would call it segmental, or sometimes it kind of overlaps between dermatomes. So these are the descriptive terms. It doesn't imply that one belongs to a specific category or another. The port wine stain, on the other hand, is really not an hemangioma. It's a capillary vascular malformation. So they are very distinct, and their etiology, their behavior, and more importantly, their prognosis. Again, a busy slide. I'm going to let you guys look at it if you're interested for the next 10 seconds. I'm going to speak, and then we'll go to the next slide. There have been a lot of theories on hemangiomas. Not one theory completely covers everything, which is why we have so many theories. All of them, although explain in part some features, some characteristics, and some behavior. Okay, so if you're interested, there's a bunch of references at the end. So again, pictures. I'm a radiologist, so I'm going to show you pictures, clinical pictures, and then imaging pictures, and then towards the end of the study say that most IHs do not need imaging. But that being said, imaging, if you do image them, there are some features with which we can characterize a lesion in the correct clinical setting as an infantile hemangioma and not a tumor or a vascular malformation. So that we can do. It's not an absolute point, but it is quite relevant in today's imaging scenario where we do image a lot of kids for infantile hemangiomas. So that's kind of what people used to call the strawberry hemangioma just because of the way it looks, a big mass. These lesions in their proliferative phase, which is between 4 to 8 months, are very vascular. So if you do a Doppler study, it's going to show a lot of vasculature. Pretty much no other lesion in infancy will have this much of vascularity, internal vascularity. There are vascular lesions, but nothing will come close to the vessel density on imaging. And the same thing translates into CT, non-contrast, contrast enhanced, intense enhancement. So it's all the same lesion. And again, MRI is the study of choice if you're evaluating a lesion for some treatments. Why? Because unlike CT, there is no radiation associated with it. You can do multiple phases of enhancement. MR has a very good soft tissue resolution. Ultrasound is equally good, but it cannot penetrate bone. It cannot go to the deeper structures. So if you're going to investigate or you're going to image something, MRI would be the modality of your choice. In MRI, the wrong button, I think. Let's go back. Okay, there we go. So 2 hemangiomas, they were imaging it to see if there was any intracranial extension. I have never seen one, but we do this imaging, at least once every year on a scalp hemangioma. So T1 images, iso-intense, contrast, bright enhancement, angiographic pictures, no intracranial extension. You do have feeders from the scalp, but that's kind of how we go. And those black dots show the flow voids. These lesions are so vascular that the blood flow itself in some MR sequences can appear as signal voids just because flow is very high. This is one of the hemangiomas which, if you see, you should be concerned. These are segmental or diffuse hemangiomas, which means they're widespread. They're not focalized. In the head and neck region, they tend to go along a dermatome, and they may sometimes have the tip of the iceberg effect. What you see is the tip, whereas if you image it, you'll see a lot more going on inside the lesion involving the subcutaneous fat, the muscles, and they can sometimes even destroy bones. That is where imaging would come into place. And these belong to the category of hemangiomas that should be imaged, should be evaluated, should be followed up, and maybe treated. So on the pictures, that's the same kid, and again, same patient. So you see really not a big raised lesion, but once you do the CT with contrast, you see a lot of enhancement in that area, but you can also see other deeper lesions involving the parotid and infiltrating close to the skull base, which you could never guess by looking at the kid or on clinical examination. Same thing here, scalp, hemangioma, nuchal region. It's raised, but you would never guess how much inside it goes. It kind of circles the vertebral column completely, goes anteriorly. Now, these are the hemangiomas you want to be following up or making sure that the kid does not slip into some sort of emergent situation. So, next slide. Hemangiomas do not always have a cutaneous lesion. When I was taught in med school, it was always like hemangiomas are cutaneous. No. There are a subset of hemangiomas, mostly in the head and neck region and also in the liver, where the lesion itself is hidden beneath the skin. There is no cutaneous marker whatsoever. Again, those are the lesions you would investigate just to make sure you're not missing anything else. So that is a lesion that is completely skin covered. The skin is fine, but when you do imaging, you see this mass, which is signal whites and has intense enhancement. Whether they are above the skin, on the skin, or below the skin, all infantile hemangiomas do involute. They always involute. So it's not a question of whether they are not, they will. It's just that can we keep the kid alive or in a healthy state to the point when they achieve their complete involution? Or, the next question is, will involution cause any harm along the way? So those are the questions you have to be treating for. So all of them involute. They don't resolve. There's a difference. When something resolves, it kind of goes away. You don't see anything behind. But when hemangiomas involute, they leave behind fibrofatty tissue. The skin over the lesion kind of gets an aged, wrinkly look. That's the way hemangiomas involute, because they are basically, according to one of the theories, they are from embryonic cells or fetal cells. So when they age, they also take away the elasticity of the fiber. So that's a nice picture. 11 weeks is when it starts showing up. They don't show up at birth. Really not a precursor lesion, maybe a cutaneous mark. And then at 7 months, it's gotten really big. You can see that. And at 7 years, it's completed its involution. It's not gone away, but there's no active enhancing soft tissue. There's just a bunch of fatty tissue. It can keep decreasing in size, but it will never completely go away. So there is another subset which I showed earlier called congenital hemangiomas. Suffice to say that these are distinct from infantile hemangiomas in that they are already grown to the maximum extent by birth. So we will touch upon it briefly later, but do not confuse this with hemangiomas. If a kid has a lesion at birth and it's not anything else and you think it's a hemangioma, it's not an infantile. It can still involute because there are two categories, the rich and the niche, but And these are the hemangiomas which, as a pediatrician or as a specialist, when you see, you should proceed with further evaluation and imaging, or at least, think about the possibility that this kid may need something. We're going to discuss them in detail in the subsequent slides, but just to show the pictures, extensive hemangioma on the face, bilateral segment, dermatomal distributions, B3. These are associated with a very high instance of airway issues and some syndrome called phase. We'll touch it later. Lumbosacral hemangiomas associated with spinal anomalies. The one in the ear can involve the parotid, and even if it doesn't, can destroy the cartilage. Even though these are benign, they can still infiltrate, erode, and destroy, and ulcerate. And images showing the same kid, not a lot of parotid involvement, but still a big enhancing mass involving the ear cartilage, which means when it involutes, it is going to leave behind a cosmetic deformity. As I said, we'll touch on this in the subsequent slides. Orbital hemangiomas are important. Why? Because, again, they can have significant mass effect. They can cause amblyopia. They can cause astigmatism. And on the pressure effect, I haven't seen a case where it actually erodes the eyeball, but there are cases in literature where they say it can at least involve the ocular muscles and sometimes even the eyeball. So what do? We first image the patient to see how much it's extending behind and if it's really causing any disturbance in vision. If it does, that gives us a good reason to treat. What are the treatment options? Again, we'll discuss it at the end of the slide, but these are the lesions that you want to follow up, to image. So kind of the theme of the whole lecture is going to be most of them are benign, but some of them do need investigation, and that is the important part. Yes, you ignore most of them, but you want to pick up those that need to be imaged, evaluated, followed up, and or treated. I think you might have read that thing, so I'm not going to go on all the images there. So beard distribution, we have seen it a couple of times, but again, this is important because the head and neck region is a region where everything very vital is kind of clamped in a very close space. So even a small space occupying lesion in the right location could destroy a lot of functionality. These hemangiomas, that's a precursor lesion, by the way. This was taken slightly after birth. So the skin markings are kind of the precursor lesions that you will see at birth. After birth, this was, I think, 2 to 4 weeks. You can see the lesion kind of forming underneath. The precursor lesions can be like just a mosquito bite, a pinpoint, a dot, a thread, sometimes just nothing. And, at a later stage, during the proliferative phase, that's humongous. He did have imaging at that time, and there was a lot of extension to the deeper structures, the parotid glands surrounding the airway, and treatment options surgically, there are not a whole lot. Reason being that it's going to involute, and again, these lesions are very vascular, so it's not like you can cut a piece and get away safely with it. So he was not having any airway compromise or significant airway compromise, so they followed up. This was before Propranolol came into the picture. They gave him steroids, and finally you can see that it involuted. No surgery, involuted, and I'm not sure if it shows up well there, but if you look at it closely, the skin has an old, wrinkled, scar-like appearance. So that's kind of what happens when those involute. So I'm going to let you guys read that. Probably would have read it, so we're going to go to the next slide. Similar picture, but again, bilateral, kind of showing how it is, and then there's an actual airway lesion causing narrowing. What did we do in this case? Again, nothing, because you can do a subglottic tracheostomy, but again, this kid wasn't having any collapse, so we waited and watched. I think this one got propranolol, got better, so surgery is reserved only in those instances where nothing else will work, and only in life-threatening situations during the proliferative phase. Once it's involuted, you can do stuff for cosmetic reasons. That is kind of beyond this lecture, but again, in children and infants, if you see a parotid lesion, it's more likely to be an infangioma than anything else. These are hepatic hemangiomas. I'm going to just rush through them because one, you will not really see them. You will have to infer that they are there by some imaging study. And again, these are the lesions which have a multitude of options. And this specific lesions, even though I put it under the hemangioma subset, it's a rich, which means the baby is born with this lesion. We had a patient like this here, maybe 2 patients in the last, I think, 4 years. Both of them did extremely well. In the beginning, everybody was concerned about it being anything else, but these are not the pictures of those patients. This is from an older patient. In like 2 to 4 weeks, you could see that the lesion had decreased in size. It was not growing, nothing else has been done, even with the propranolol, and I think after propranolol, it went down. So the rich-like lesions are present at birth. In fact, they're diagnosed prenatally. This is the lesion which people used to call in the older times as hepatic or infantile hepatic hemangioendothelioma. Again, please don't use the terminology. I'm just saying it for clarification purposes. They involute so rapidly, but before they involute, they have a huge flow through them. That might cause a cardiovascular compromise or collapse. So if you manage the patient over the time, the lesion will involute, and then in 2 or 3 years, all you will see is a chunk with a lot of calcifications. And the second one is multiple hepatic hemangiomas, and the third one is going to be diffuse. The difference between these two is diffuse, you can't really count. I mean, there's so much you don't want to count, believe me. And multifocal, you can still count. Yeah, it's going to be a pain to count, but you can count. These are your infantile hemangiomas. They come after birth, they behave like it, they grow, and then they involute. The effect mainly comes from the number of lesions. In hepatic hemangiomas, usually they're asymptomatic because there's not a whole lot to cause CHF. They behave on imaging like a typical infantile hemangioma. And the diffuse one, there's so much that they can cause vascular collapse, and they can cause hepatomegaly and compartment syndrome. And an interesting thing is, all the lesions do it, but diffuse lesions express more of this enzyme, which can lead to hypothyroidism just because of the huge tumor mass that's present. And these are not infantile hemangiomas. Yes, they are lesions, they are vascular lesions, they are vascular tumors, but no, they are not infantile hemangiomas. They share some histopathologic features. They are not GLUT1 positive. For infants, the only tumorous lesion that is GLUT1 positive is pretty much an infantile hemangioma. So we're going to go to the next slide. This I'm going to spend some time because most of you, if you're practicing with kids over 15, will have results, ultrasounds and CTs, whatnot, saying hepatic hemangioma, benign, no need to follow up. And then the question comes like, hold on, this kid is 15. How can he have an hemangioma? That's because it's a misnomer. We have been calling this an hemangioma for God knows how long. And I'm pretty sure we as radiologists, the adult radiologists, will still continue to call it, even though we have seen some changes in the last few years. That is a slow flow venous or vascular malformation. You do not see it in babies. The appearance is distinct from that of babies. It's going to be very echoic. Infantile hemangiomas, hypoechoic. They will not enhance in the arterial phase. They have a delayed centripetal enhancement, something which kind of we humorously call like the mother-in-law pattern. It kind of starts late, keeps on accumulating and never leaves it. So the mother-in-law kind of anyway. So that is not a hemangioma. That is not an infantile hemangioma. So please don't confuse it. So coming to cutaneous hemangiomas, when you see a lesion there, the one thing you want to make sure is that, again, the hemangiomas themselves, if they're small enough, will not cause any harm. They may be cosmetic, but they're going to involute. They will involute really well. They're not going to cause any harm. But sometimes they act as a flag for something that's going on underneath, because all these things, when the fetus is formed, kind of go together hand in hand. So if you see hemangiomas in certain locations, it could imply that something else might be wrong along the same dermatome or along structures that develop at the same time. So lumbosacral hemangiomas, you can see them, or midline hemangiomas can be associated with spinal dysraphism or tethered cord or occult spinal dysraphism. And then we have got a bunch of syndrome. We got pelvis, we got faces, and we got a bunch of acronyms there. Pelvis stands for that whole bunch. The idea being that if an hemangioma that is big enough is seen there, just because of the location and the fact that structures tend to develop about the same time during the fetal period, you have to look for other things. So it might be there. If it's not there, it's well and good. But these are the patients you want to investigate, to make sure that nothing is wrong, or if you see that something is wrong, to follow up and make sure that they don't go into a sudden obstruction or neurologic deficit, etc. So again, the perineal hemangiomas can involve the scrotum, the perineum, the labium, and these things tend to ulcerate more than the head and neck lesions, just because the head and neck lesions are usually very vascular. The head and neck itself is very vascular. Your face is much more vascular than your extremities. So these lesions and the ones in the extremities tend to ulcerate, which is the most common complication of an hemangioma. If you had an infantile hemangioma, a big one, the most common complication you would expect it is ulceration. Why? Because it turns an asymptomatic lesion into a symptomatic one. They still have nerve fibers, so once it ulcerates, you're going to feel pain. It's going to irritate the baby. The baby is going to be inconsolable. And we'll come to the ulceration part later. This is phases, and again, all those letters stand for all those things, so you can look at it. One interesting thing is that you do not need to have a cutaneous hemangioma to have phases. Just as I said, the hemangioma could be completely underneath. So you don't need to have a cutaneous hemangioma. They keep on revising those criteria. I think this was the one I took 5 years ago. But this is a nice picture. You can see the hemangioma itself, the fact that the carotid is small, dysplastic, and then you have an aortic coarctation. And this one did not have a sternal defect, but you don't need to have all of them to be called the phases. And what you do, you just wait and watch. You can treat with propranolol if it's life-threatening. The vascular lesions do not really go away. Once it's a dysplastic vessel, it very much remains that way. And these kids usually do not have any significant ischemic areas or infarcts because it's not an acute event. It's been developing that way all along. And the coarctation can be repaired. And let's see, parapharyngeal. Again, the nipple hemangiomas are important mostly in females rather than males because if it involves the breast bud, it's going to destroy it or infiltrate it. And if it does, you're going to have a cosmetic issue. Yes, you can also have ulcerations, which can lead to discomfort, but on a long-term basis, you can have significant dysplasia of the underlying breast tissue. So another reason to check if it's involving it or not, if you can pick it up in the early stages, let's say around a month, then you can think about treating it or even thinking of a surgical compromise, surgical intervention to see if you can save the breast bud. Because once it goes into the proliferative phase, once it's actually involved the breast bud, there's not a whole lot you can offer by surgery. Then you have to go to medical management. And but again, it mostly cosmetic. So again, nice pictures. That one is very close, but not really involving the breast bud. This one, the breast bud is involved, and again, that one is an ulcerated lesion. Okay, so the treatment part. So do we treat infantile hemangiomas? If it's a small one, if it's not really bothering the family, it's usually the kid who is completely fine. He may have a big hemangioma, but the baby doesn't care. He just plays around, he's happy with it. He doesn't give a shit. Excuse me, but he doesn't. The parents, on the other hand, they freak out. Even though you tell them it's an infantile hemangioma, no. They want it gone, and they want it gone like today, right now. Why? Because we live in a world where appearances matter and people, insist on getting the thing out. So that's why I put that as one of the causes. And it's still valid. Believe me, most of the hemangiomas that we treated, at least when I was involved in this project, were not for the endangering part. Well, they got treated anyway, but most of it was for the parents. It didn't really work. It was more like a placebo. We would give them propranolol. We'll say it's going to involute. The parents were happy that they were doing something. Yes, propranolol did help. I'm not saying it didn't, but it's not the magical cure you want. So you do it for that purpose. And the physical complications and deformities in hemangiomas that are not endangering, but which have gone ulceration. Let's say you got an hemangioma about a joint which is ulcerated, it might lead to a contracture. So you might want to treat it sooner than later. And finally, the endangering hemangiomas. Those are the lesions you would follow up and decide if it needs to be treated. If it needs to be treated, then you would evaluate the options. Medical management, pretty much everything under the sun has been tried at one time or another for hemangiomas. because these lesions are not new lesions. They have been there since humans were there, since babies were there. A lot of things have been tried till recently. When I say recently, I use it in a loose term because when I started in 2010, it was probably really recent, but in 2016, not so much. At the time, around 2005-6, steroids were kind of the mainstay, because steroids were, at least where I come from in India, steroids were used for everything, and people were happy with it. Same thing with hemangiomas. It does help, but it does have a lot of side effects. And hemangiomas are things which you can't just treat with a pulse therapy. No, it's something which is going to be there for at least an year before it starts to involute. So steroids, but now I'm going to speak about propranolol in a separate slide. And then the idea is to avoid procedures that can cause more harm than benefits, because we all know that infantile hemangiomas will involute no matter what. Yes, they can ulcerate, they can cause issues, but they are going to involute. It's not a tumor which is going to keep on growing. So it's not going to metastasize. No, it's going to involute. You can still use topical steroids, but again, with the advent of propranolol, this is kind of a debated thing. As I said, they have a side effect profile which is not favorable, steroids. People speak about lasers for anything in dermatology, and for infantile hemangiomas, that's not true. No, not really true. But that being said, like with any rule in life, there's always an exception. So the exception here is that you treat for very focused indications. One of them is ulceration. When the lesions ulcerate, happens more often in the extremities and in the pelvic lesions, they irritate the baby very much. So you want to give the baby some relief, and you also want to protect the surface from getting infected. Now that laser at that wavelength can coagulate only for a very small depth, really small depth. So when you use that laser, it's going to coagulate the surface nicely. So you get a surface where the nerve endings are dead, where the surface is smooth, and it cannot get infected. So that is what you use laser for. The second thing is, after a lesion is involuted, or what you have is only a skin thing after the lesion underneath it is gone, then you can use laser to remove that lesion. So otherwise, not really for proliferative phase hemangiomas, not to debulk it, not an option. Finally, propranolol. When I first gave this talk in 2010, it was still not FDA approved because this thing had been found in France in a big hospital treating pediatric heart patients. They had a lot of patients with hemangiomas and heart disease. They were treating heart disease. The hemangiomas just started to decrease. Somebody linked it together. But it was approved in USA in March 2014. There's a specific name for the preparation. I think it's called Tegmarol something. You can Google it. But now it's the mainstay for drug treatment of infantile hemangiomas. The mode of action is still not completely clear. There are many proposed hypotheses, but we know it works. So if it works, let's go with it. So we are giving it. And nice picture showing side by side an orbital hemangioma before and after. You can see that it doesn't make it vanish. It decreases its size. It kind of holds it that way till it can involute on its own. So it's not going to resolve it. It just keeps things in hold. It decreases the size so that the parents feel a bit more comfortable. It does not make them vanish. And nothing makes hemangiomas vanish, by the way. It just goes on its own. Same thing, large nuchal hemangioma, same kid we saw before, went down quite fast. All hemangiomas do not behave the same way with propranolol. Some respond better, some respond bad, but usually they respond. Okay, so finally, as a radiologist, what is my role in infantile hemangiomas? For 90% of the lesion, none. You should not even be sending those patients to us. No, end of story. If you think it's an hemangioma, head and neck, focal, the typical history and all the things, no need for imaging at all. But if you do send them for imaging, we would rather have them for these reasons. The ones that we discussed earlier, multiple cutaneous hemangiomas, I don't think I showed it to you, but if there are multiple, let's say 10 or more than 5, there is a chance. There's a placental theory which says it could have been a shower of emboli. So there's a chance that in those patients they can have visceral hemangiomas inside the skin that you're not seeing. So image them. Peer distribution, image them. Why? Because for airway compromise. Orbital hemangiomas, if it's big enough, image them. Or if you think it's going inside, image them. Midline hemangiomas, image the spine. Perineal hemangiomas, look for other anomalies, appropriate imaging. Fate syndrome, this is quite appropriate. Now, we may not treat it, but it's good to know if there is anything that might lead to a sudden compromise. Now, what are not hemangiomas? If a lesion happens only at 6 months of age, and the mom is sure that it was not there before, not a hemangioma. I've seen neuroblastomas, rhabdomyosarcomas, all those things being, kind of said as, it's a vascular lesion, only to be found out at a later stage that it was something else. So if you have a doubt, if the history is not good, imaging those lesions might help you decide. Now, imaging is not absolute. So what is? The duct test. So I like the duct test because it's a common sense thing. So if you look at a lesion, you know it came after the birth, it wasn't there at birth, and it's growing appropriately, then you call it a duct, or in this case, an infantile hemangioma. So physical exam is important, but more than that, the temporal sequence of events. When you got the lesion and how it's behaving, and if you put them all together, you will have a pretty good answer. So if you have that answer and you're quite confident, no imaging. Well, is it absolute? Well, like anything in life, nothing is absolute. Once you can have a mutant span or an actual span which thinks it's a duckling, or people think it's a duckling. So when you come to imaging, what do? Can we always absolutely characterize it? No. For the most part, yes, we can tell you that it's probably likely to be an infantile hemangioma, but I hate flowcharts, let me be honest with you, but we had to have a flowchart, so this is it. If you have questions, then you go along the pathway. If you don't like the pathway, you can just go and do whatever you guys want. It's still going to be either ultrasound or MRI. You'll still get an answer. So we'll go to the next one. So take-home points. So at the end of this lecture, what I want you guys to do, even if you forget everything else, please stick to the correct terminology for infantile hemangiomas. If you're not sure, then don't call it an hemangioma, because in the day of medical records where things go very fast, the next person who sees it will most likely not even see the patient. I mean, in this day and age where we spend more time on charts than patients, it might happen that the chart might get, kept on carried over, and the hemangioma's tag might stay. I've seen kids come at 15 years with a vascular malformation that had for some reason been tagged hemangioma, and then everybody else started calling it hemangioma. So please stick to correct terminology. And how do you do it? Only if you spend enough time. Due diligence is the answer. Nothing beats it. Due diligence. Once you're sure, no imaging, right? Well, we would like to get business, but for this, for babies, for MRIs, they have to undergo sedation. So they'll be fine with all those imaging studies. You do want to recognize those ones which can lead to complications. So that was the other emphasis on this talk. Beware of lesions that appear after 6 months. And if you're going to go to tissue, GLUT1 staining is recommended, because GLUT1 can be positive in other lesions, but in that age group, that subset, among those lesions that you're looking for, infantile hemangiomas are the only lesions that are GLUT1 positive in that subset. Imaging can suggest a diagnosis, but it should not be for diagnosis. And it's not absolute. It's for other reasons. Propranolol is currently the drug of choice. It has been FDA approved in 2014. And those are the references. If you're interested, nobody is usually interested, but still. If they are, these are the references. And thank you all very much. I just put it because I thought it kind of conveyed the patient I got with a hemangioma tag, which was not a hemangioma. So when we specialists put a tag on something, it doesn't have to be true. It could still be wrong. So it's up to you guys to start it. Any questions? Okay. I'll take that as a no. And then.
All right. Thanks, Dr. Palani.